Maybe we can wait 1 minute more because a lot of attendees are connecting.
Maybe, Stefan, if you can stop your microphone just for a few seconds, or. Dear colleagues, dear friends, it's a pleasure to be with you this afternoon for a new webinar organized by the Eans skill-based section. The topic today will focus on the pterional approach. We make the choice to focus on the different approach that we face in our practice, from the basics to the more complex one. And today we will discuss a more basic approach, a common approach, which is the pterional one. We have with us to start again, as you have seen and meet him in the previous webinar, Stéphane Lieber from Paris, who will discuss with us some important anatomical aspect when approaching this region. I will discuss with you the more classic pterional approach just afterwards. Jan Frederick Cornelius from Düsseldorf will focus on the mini-pterional approach. Then Eckhard Kasper from Boston will discuss the management of giant olfactory growth meningioma through this approach. And we will maybe have the chance to have finally with us at the end of the program, Sebastian Fröhlich, if he is able to join us. So just to start, Stefan, please, up to you to show us your very nice anatomical illustrations that you have already shown in various situations. And of course, I'm sure that they will be pretty for the pterional approach. Please, Stefan.
Thank you very much. Thank you very much for the invitation again. Is the microphone working?
Yes.
Perfect, wonderful. Okay, so topic of this webinar is the pterional approach, and what is labeled as the pterional approach, I think, is in fact the beginning of a mini-series, not only on the pterional approach, but on the far lateral corridor. So the extension of the pterional approach, the far lateral, the FTOZ, the mini-pterional lateral orbitotomy, supraorbital keyhole approaches. All these approaches derived from the original, or the extensions of the original description of the pterional approach by Yajogil. And I decided to do a brief review of course, of the anatomy for this approach. But since we have this mini-series starting on anterior clonolectomy, FTOZ, orbital approach, anterior petrosal approach, subtemporal extensions, I decided to split the anatomy a bit and will focus some of the intradural anatomy, orbital anatomy for the FTOZ, for example, in a later webinar, and we'll focus this talk more or less on the soft tissues, facial nerve, muscle preservation, where to place incisions, boreholes, not the technical side, but the anatomy, and why this is important for the outcome of surgery and reducing patient morbidity for these very common workhorse approaches as we use them on a daily basis in neurosurgery. This, of course, is not a pterional approach. This is just a depiction of the lateral corridor that can be exposed in this FTOZ extension from the temporal tip, pretemporal extension, subtemporal extension.
Stefan, your presentation is not visible.
It's not visible?
No.
Just a moment. there it is, okay. Better now?
Yes, it's
Yes.
perfect.
Okay, perfect. So as I said, just an overview for the anatomy, beginning of this mini-series on the anterolateral corridor to the skull base and the orbit. This again is not the pterional approach. This is the exposure that can be gained with the extension of the pterional approach, everything from a subtemporal approach, pretemporal approach, an FTOZ, including the orbit, the combination of access to the temporal, middle fossa, anterior, frontal region, subfrontal exposure. Of course, that's the original description or utilization of this approach by Yazegil, entry into the Sylvian fissure and the insula, the deep assistance. This is the initial description of the pterional approach. Of course, this is a Sylvian split on the right side, temporal side up here with the superficial temporal vein that runs temporally, frontal lobe exposure of the chiasm here, proximal M1 anterior circulation with the recurrent Huebner's artery. All this can be exposed, optic nerve, third nerve. All this can be exposed in this with this Sylvian split. For vascular neurology, oncological surgery, access to the cistern, suprasellar space, and all this. This is just another example a bit further down, mobilization of SCA and PCA, third nerve chiasm here, and anterior and middle circulation. This is the deep anatomy that can obviously be reached. This will not be the focus of my talk, however. This is the skull base section, and this is just an overview. And as I said, I will be focusing this on soft tissue preservation and with the extracranial anatomy, mostly in this first talk, and then later talks on anterior petrosectomy will include the mistal fossa peeling, anterior clownodectomy will include the orbital cavernous junction, and the FTOZ will include the orbit structures. This again being the entry into the and middle fossa as described by Yazegil, the extension in subtemporal region for the anterior petrosectomy, medial lateral wall of the cavernous sinus, access to the orbit, and then the frontal extension for lateral mini approaches into the anterior cranial fossa. So of course we're dealing with the anatomy, which is known. The pterion describes this region of the fusion of the mostly the sphenoid, the greater wing of the sphenoid. We have this between the frontal and the sphenoid. The frontal is a bone and the zygoma and the temporal bone, the zygomatic process within the temporal bone, the squamosal suture, the sphenoidal squamosal suture. So this is the region which is the lateral extension of the greater wing of the sphenoid, which describes the border of the anterior fossa and the middle cranial fossa. This is the original idea of placing a borehole in this region to enter either frontally or inferiorly into the temporal bone. Of course, there's variations of this borehole. Whether the borehole is needed for a frontal craniotomy, then it's a frontal borehole, which is a bit superior and anterior to this. McCarthy's borehole, the borehole that exposes both orbit and anterior cranial fossa, is yet in a different position. All this will be covered in a next talk. And then of coronal suture, the lateral aspect of the skull in this perspective. This is best understood with split bone models. This is the sphenoid. This is the greater wing of the sphenoid here, which extends laterally, connects with the frontal bone anteriorly, the temporal bone laterally. And this is the superior optic fissure, optic strut, optic canal, anterior clinoid. This is obvious anatomy. And this is the position of the pterion, which is, as I said, the junction between the lateral extension of the greater sphenoidal wing, where it connects with the frontal bone, and the parietal bone supra-posteriorly, and the squama of the temporal bone. This is just another perspective for essentially the same anatomy. This is again the anterior anteromedial aspect of the middle fossa, with the anterior clinoid lateral extension of the greater sphenoidal wing. This is the region of the temporal pole, and this is the connection between the squama and the connection here superiorly with the frontal bone, to the sphenoidal bone. This is the temporal sphenoidal suture in this disarticulated skull model of this right middle fossa. This is now the connection between, this is the anterior aspect of the pterion from the extracranial perspective. This is the intracranial perspective, which shows you the frontal burr hole here, which grants access, for example, for a mini frontolateral approach, a submuscular burr hole in this region, a bit posterior, right on the extension of the lateral, of the greater wing of the sphenoid, would then be the pterional burr hole, or the keyhole as commonly known. This is the junction here between the sphenoid and the frontal bone. The same junction in this posterior anterior perspective, we'll be having, I think, another talk on olfactory groove meningiomas, so a bit of fossa anatomy is included in this. This is obviously the frontal bone, ethmoidal bone with a cribriform plate in the middle, the crista galli, and this region of the olfactory system. Then the connection with the planum sphenoidale, the frontal sphenoidal suture here, and again the lateral extension between the lateral frontal bone and the sphenoid wing. This is the intraorbital perspective with the frontal bone, the superior orbital fissure, the optic canal, optic strut, the greater wing of the sphenoid forming here the lateral orbit, and again superior temporal line, the attachment of the temporalis muscle, the orbital process or zygomatic process of the frontal bone connecting with the zygoma, and again this is the region of the keyhole. These are the sutures here. You can actually see them in the split bone model, and again superior supraorbital notch and or foramen, in this case a foramen, in this case a notch. As part of the orbit will be discussed in the course of the FTOZ module coming up in some of the next weeks. This is the same anatomy. This is not a split bone model, just showing you some of the anterolateral of the lateral orbital rim. Everything from temporal zygomatic suture here to frontal zygomatic suture. This is the region of a frontal keyhole. These are the sutures forming the pterion. This is sphenoid, this is temporal bone or squama, this is parietal bone, and this is the extension of the frontal bone. I think this is a bit, this we discussed, maybe just mentioning when we do supraorbital, the lateral extension, mini-pterional or a supraorbital approach, which is essentially the frontal variation of a pterional approach, although it doesn't really involve drilling of a pterional keyhole, but a frontal keyhole. These are the orbital gyri, which need to be drilled down when access to the medial structures or the olfactory groove is needed. This is the only surgical or intraoperative picture of my talk, just to illustrate the necessity of soft tissues for all these approaches. So this is the harvest of the pericranium on this side. This is a right-sided exposure. This is pericranium. This is temporalis muscle. Obviously, this is the galea, which has been retracted. And that's the technique we're using here in Paris, doing a lot of skull base, preserving tissues, and also harvesting tissue for closure of defects, avoiding non-autologous material. And this shows the harvest of the pericranium on this side, exposure of the fascia of the muscle, already the incision of the interfascial fat pad for mobilization of all these tissues, and harvest of the pericranium. As I said, this talk will be, since this is the entire approach for the next 4 talks coming up on anterolateral corridor, I will focusing on tissue preservation, which is everything from suturing bipolar of tissue just underneath the skin, preservation of superficial temporal artery and other arteries supplying the scalp, preservation of the muscle, preservation of the facial nerve, preservation of supraorbital nerves. So essentially preserving, reducing morbidity for the patient. And this is just to illustrate the layers of the skin as usually exposed, and the rootlets of the the skin, which needs to be preserved as much as possible. So cauterization of this level obviously needs to be reduced to a minimum with a fine bipolar. This is exposure of the temporalis fascia. Vessels run in the fascia and the pericranium very deep, and can usually are of such a caliber that they can be controlled and preserved when necessarily transgressed in course of the incision. This is just showing some of the vascularization. Obviously, this is the superficial temporal artery, a branch of the maxillary artery with its anterior frontal branch and the parietal branch. There's some variation, but usually there's two branches and connect in a circle. Usually there's some anastomosis also with the supraorbital, supratrochlear arteries exiting the orbit. This is the vascular arch, which needs to be considered when incisions are taken, and is part of preservation of function. Sometimes, obviously, these are needed for bypass or for other purposes. As I said, vessels run in just underneath the fat, either on the temporal fascia or directly on the pericranium. This is the thin fronto-occipital muscle, which blends into, this is the fronto-occipital muscle. Just here you can see some of the thin nerve fibers of the supraorbital and supratrochlear nerves, the vasculature as I discussed, and a very thin periorbicularis oculi muscle, which blends in the fascia in this region. Obviously, again, preservation of either the stem or the interior branch of the superior temporal or superficial temporal artery needs careful placement of the incision. As for all the lateral corridor incisions needs more extensive, more inferiorly towards the zygoma. Sometimes superficial, just above the zygoma, but as I said, FTOZ needs a more inferior incision to mobilize the soft tissues over the orbit once everything is anteflected. So this needs careful planning, and usually it needs to be as posterior as possible. It's not a mistake to expose some of the cartilage to make either that first the vessel can be dissected and control at a safe distance to the frontotemporal branches of the facial nerve is provided. Preservation of the facial nerve branches is obviously a focus of any anterolateral perspective. As we know, the facial nerve exits the skull base at the start of mastoid foramen, then courses in the parotid gland between the superficial and the deeper layer of the parotid, and then ascends in various bundles towards the front and towards the orbit. And the incision, as I said, needs to be taken as posterior as possible to avoid damage of the facial nerve. This is a dissection of the facial nerve. We are talking about the fat pad. As I said, there is the main stem exiting here from the stylomastoid foramen. This is the tip of the mastoid. This is the cartilage of just anterior to the tragus, the cartilage of the ear structures. We have ascending the relatively posterior. We have ascending the superficial temporal artery and these branches of the facial nerve. This is the level of the temporomandibular joint. This is the root of the coronary, the mandibular process, and again facial periorbital muscles. The fat pad is important to control. There's various techniques. I will not delve into techniques. I think we'll be having another talk on this in just a moment. But obviously, control and knowledge of these spatial relationships and these fascial relationships are very important. So this is a coronal view depicting the temporalis muscle, which connects to mostly the coronoid process of the mandible, big muscle of mastication, and the facial. There is a superficial temporalis fascia and a deep temporalis fascia on the outside. The deep temporalis fascia is the inner of the fat pad in which the facial nerve runs, and the outer surface is the connection. Both of them blend into in the region, usually in the region of anterior aspect of the superior temporal line. And this is the space that needs to be controlled, superficial and deep temporalis fascia to safely mobilize the skin with the facial nerve from the muscle and to reflect them in different regions. There's different techniques, as I said, I will not dwell into this, but this is the anatomical basis for its control. This is, again, is just a perspective of an incision. This is the region of the pterion. This is the lateral canthus region. This is the muscle that can be seen here. And this is the region of the muscle where it blends into the pericranium underneath. And then along the superior temporal line, the temporalis fascia splits into its superficial and deep leaflet and develops a fat pad. This is the beginning of the fat pad on this side, where you can where I dissected some of the fibers, some of the facial fibers out of this fat pad. This will be seen in some of the next slides. This is very important to control, and it's necessary to keep retraction to a minimum. It's necessary to keep bipolar to a minimum, and it's important to stay on the in order to separate the muscle and the skin flap for mobilization. It's important to stay in the level of the deep temporalis fascia and to keep the nerve in the fat pad with the skin, which is anteriorly usually. This is just a depiction of the fat pad. This is again a right side. This is the superior temporal artery, orbicularis oculi muscle, and these are the nerves in the fat pad. This is the outer layer of the fat pad. This is the deep fascial layer, and in this vast fat pad, there's a big number of facial fibers, which are impossible to control once entered. They're too thin. They are in the fat pad and not be visualized even under the microscope. So it's important to recognize the layers and not enter into this fat pad. This is just a depiction of these fibers running in the fat to outline the fact that it's not possible to dissect them even under the microscope in a surgical setting. This is essentially the same, again, ascending fibers from the ear towards the periorbital muscles. This is a full dissection of the facial nerve fibers, the frontotemporal fibers connecting to the frontoccipitalis muscle, the orbiculi, important and structures, obviously, for not only for cosmetic reasons. And this is the entire facial nerve from its main stem, main branch here in the mastoid region, ascending towards the front. This is usually we control the facial nerve on its lateral aspect, so we keep the fibers with the skin. This is a dissection I did for a lateral orbitotomy. So this is a canthal incision. This is an approach where the facial nerve is kept on the soft tissues on the lateral side. So and as you can see, this is again the orbicularis oculi muscle, and in the pericranium, in the deep fascial layer. These fibers course very close to the orbit, into the eye. This is always the case also in eyebrow approaches. There's always some facial fibers that course into this direction. So not only the knowledge is important, again, for retraction, for the direction of the incision, this is the anatomical base for minimizing morbidity in this region. This is a beautiful paper, one of my favorite papers, and one of the last papers of Professor Roton's lab in Gainesville, which is a beautiful demonstration of exactly this, also describing some of the techniques, how to preserve facial fibers running in the fat pad and then exiting the fat pad once the deep temporal fascia and the superficial temporal fascia join again here in the region of the superior temporal line, the attachment of the muscle. So in this region we have three facial layers. So we have the bone, then we have the deep periostal layer on the inside of the muscle, which is usually first, but needs to be preserved on elevation of the muscle. This is another technique. The fascia, that's the layer in which the tiny nerves and vessels for the supply of the muscles run. Then we have the temporalis muscle, the deep fascial layer, which is the layer which is exposed in interfascial dissection. Then we have the interfascial fat pad, which contains the nerve, and the superficial facial layer. And all these merge at the anterior at the anterior junction with between the side of the pericranium and the muscle in the anterior aspect of the superior temporal line. And this is exactly the point where usually it gets a bit stretched. You want to disconnect the muscle. You have to do some retraction. This is the point of maximal retraction for usually the anterolateral corridor. So in this paper, not only very nicely describes the anatomy, but also some of the things not to do, in which direction not to cut, obviously not to disconnect the facial nerve, which runs in this region right into the skin and just above the pericranium on the medial side. Also, obviously, no polar needs to be used to connect the muscle from the lateral orbit. Bipolar needs to be minimized, retraction needs to be minimized, and all this is beautifully illustrated in this paper. Coming to the temporalis muscle, obviously this is the biggest muscle of mastication, has obviously also cosmetic function. The particular arrangement, the most important part, not only for cosmetic, or this is in the hair, but also for the mastication function, is the anterior aspect. Connection, as I said, is the attachment of around the superior temporal. And it's important to recognize the course of the fibers here along this is again a right side along the lateral orbit, and the horizontal course and when it comes to the zygoma. So whenever the muscle needs to be cut, and there is obviously cases where it needs to be cut, it should be cut in the direction of the fibers to minimize loss of function, scarring, pain, volume loss, and all the problems we know. This is recognized. This is a big muscle, which, as I said, in the coronary process of the mandible mostly, and is supplied by on the other side, as we've seen by the superficial temporal artery, and on the inside by the deep temporal, usually 2 or 3 branches of the imax recurring from the infratemporal fossa that run on the inside of the muscle, and they branch out. And the part we are dissecting, the part of the muscle we are usually mobilizing in our retrograde dissection technique, these vessels run on the inside, on the deep temporal fascia, the periosteal fascia of the temporal nerve, and need to be preserved as much as possible, moving by not using monopolar, by limiting bipolar hemostasis, and by using a technique in which the periosteum of the temporalis region is kept with the muscle. Nerve supply is as for our mastication muscles, the minor portion of the trigeminal, which branches again in the infratemporal fossa. Speaking of infratemporal fossa, just saying all these function and vessels and nerves be destroyed in endoscopic approaches to the infratemporal fossa. This is true not only for the temporalis muscle, this is true for all mastication muscles, and the vascular supply of the muscle, as I said, is the superior temporal artery and the other branches from the proximal imax. This was just, as I said, a review of the soft tissues for anterolateral approaches. I will be focusing on cavernous sinus, petrosectomy, peeling of middle fossa, orbital anatomy for the FTOZ, some of the keyholes for anterior fossa in some of the future talks. And I thought this would be interesting and necessary, because this is, again, a very frequent approach in neurosurgery. As usually, I want to thank all my mentors in neurosurgery, Sebastian Fröhlich here in Paris, my former anatomy mentors and friends in Pittsburgh and Stanford. Thank you very much.
Thank you so much, Stefan, for this very illustrative talk. As usual, your talk and image are truly impressive to see and allow us to perfectly understand the anatomy of this region. I will now speak with you of the more conventional, the classic pterional approach, which is one approach that is commonly used in our daily practice. This conventional approach will allow us to access many pathologies, by sample vascular pathologies, aneurysm, of course, sylvian aneurysm, cavernomas, but also tumors, not only skull-based tumors or meningiomas, but also glial tumors located in the frontal or temporal lobes. It will also be an access for functional surgeries, just like epilepsy surgery, if you would like to perform an amygdalo-hypocampectomy or other finally various disorders. If we focus a little more on skull-based meningiomas, you will have facing this bone opening the meningiomas of the lateral and middle sphenoid wing described in the Almefti calcification. You will have also the meningioma of the optic canal and the orbit. You could also use this approach for tuberculum cellae meningiomas or olfactory growth meningioma, as it will be discussed by Eckhard Kasper, but maybe for those tumors, you will have a more dedicated approach, maybe more a lateral supraorbital approach, and you can see many variations around the pterional approach, more focusing on the frontal part, more focusing on the temporal part to access various regions. It is also an access to the orbit. You will be able to treat sphenoorbital meningiomas, and you will have also access to more temporal, the temporal base, if you would like to reach a cavernous sinus lesion or a Meckel's cave tumor. This is the conventional approach. How I do it to make this pterional craniotomy. The patient has his head turned from around 45 to 60 degrees in this situation. The incision is made in the frontotemporal region as a question mark. What is important when you perform this incision, you are beyond the hairline, and we use the same paper as reference as Stefan Lieber. And you will see the temporal extension of the incision should be, if you would like to perform a conventional approach without any risk, the incision should be above the zygomatic arch and within 1 centimeter anterior to the tragus. As soon as your incision is not extending more caudally or more anteriorly, you will not damage the frontal branch of the facial nerve, and you will be perfectly safe. One thing, I make the incision directly with the knife through the bone above the superior temporal line, and a more superficial incision to respect the temporalis muscle below this line. Contrary to what is done in Paris, I directly incised in order not to harvest the fascia, the pericranium, and alleviate directly the pericranium with a spatula. It means that there is absolutely no risk to damage the frontal branch of the facial nerve. And if I have to harvest pericranium, I can do that at the end of the procedure. Then, using scissor, and I will discuss with you more technical details aspect of the approach, I incise the temporal fascia in the caudal direction. What is important when you arrive in this region is to preserve the superficial temporal artery running here, and then to preserve the frontal branch of the facial nerve. For this purpose, I invite you to put your incision in a posterior direction. Putting in an anterior direction could damage the frontal branch. In the posterior direction will be more safe to do that aspect of the opening. You have to preserve, of course, and it is from the same paper, the branches of the superficial temporal arteries in order to preserve the vascularization of all the structures, including the temporal muscle. Now I elevate with a spatula directly again the muscle with a posterior to anterior direction in order to make not an interfacial dissection, but a subfacial dissection. And you have to repair here the change in the color. This is the beginning of the fat, and you have to protect this fat. You can incise the fat here, making an interfacial dissection, or go below the fat, making a subfacial dissection. Here I'm incising, and you will see the difference between the subfacial dissection I will done and the interfacial dissection. This is the seminal paper that was also described by Stefan. How to do that, very important. supericranially above the temporal line muscle and subfacially or interfacially below this line. This is the important maneuver to do in order to respect the fat and the facial nerve. Then, caudally, you will gently incise the aponeurosis with your scissor, also again in a posterior direction. Then the fat pad is elevated in one piece very easily. Here you expose the orbital rim, and then very quickly the fat pad is mobilized anteriorly. It's a question of seconds to do that in one block, and the facial nerve is protected. Then to go, the next step of your approach is to incise the temporal muscle. I usually leave a cuff of 5 millimeters of muscle at the superior border of the muscle in order to allow a final reapproximation of at the end of the procedure. When I'm just close to the fat pad, I use a retractor to protect against eating, and this is the anterior incision of the temporalis muscle. The posterior incision is made along the sense of the fibers in order to destruct as less as possible the nerve. And as explained by Stéphane, it is important to have a respect of the periosteal fascia below the temporal muscle in order to preserve its vascularization and innervation. This elevation is truly important to protect the muscle. Then for placing the craniotome, I just made a small anterior incision in the muscle and a small posterior incision. Then we have to drill the first bore hole. Usually the conventional bore hole, for the keyhole approach, is located here. I use a bore hole in the depression of the pterion, of the sphenoid bone. And the goal is to expose the temporal and the frontal durameter. This is the temporal durameter, and I will expose here the frontal durameter, leaving just in place, you will see a small part of the sphenoid bone that will be break with a gouge, a ronger. You see here the temporal durameter, the frontal durameter, the crest in between that can be released with a gouge very easily. Then I make a posterior bore hole, expose the dura, just place a hook. I don't detach the durameter all over the craniotomy size, just at the beginning to place the craniotome. And then I use 4 cuts. If you have 2 bore holes, I'll invite you to make a first cut with the craniotome in this direction and not to go to this direction, but start here again and go to the middle, meaning that if you have a dural bridge here, you will not disturb and disrupt the dura for a long distance, but only a very short distance. Take the benefit of the 2 bore holes that you have in order to decrease the risk of big durameter damage. This is the size of the conventional approach for this pterional approach. Then I make stitches to elevate and fix the durameter. I usually put directly a knot, meaning that if you would like to do that, in order to allow a perfect and easy closure, you have to place your suture very close to the bone. If you place the suture here, you will have retraction, and it will be very difficult to close the dura at the end. What is important and what I do usually during the pterional craniotomy is to drill the bone anteriorly. As much as you drill the bone, as much as the brain has not to be retracted. So I elevate the dura from the crest of the sphenoid bone, and this bone is resected with gouge and with the drill. Just one technical point, since we are speaking on the basics for this approach. When using a drill, if you use the top of the drill, there is a risk of slipping and damaging the surrounding structures. The main point is to have a look on the equator of the drill. And if you use, in fact, the inner aspect of the drill, there is absolutely no risk to slip, contrarily to the outer aspect of the drill. This is the further opening, the drilling. One other aspect which is important when you take the drill is that when you use the equator of the drill, this is the area of the drill that is the most aggressive one, contrary to the tip of the drill, which is less aggressive. When you look at a drill, you will clearly see that. So depending on the way you place your drill, you will be less or more aggressive with the bone and the dura, which is just close to the bore. Then you expose the meningo-orbital band, and if you would like to have a more deep exposure, you can coagulate this band because there is a small artery inside, and then cut the band very safely in order to go more deeply, and you can reach by this way the anteroclinoid process. This is the conventional pterional approach that I do for a lot of exposure. I end the approach by putting stitches here. It will avoid contamination with blood coming from outside. Very important knot to place. The dura opening is made in this fashion, and then I place cotonoid in order to avoid contamination inside. This is the vision after closure. This approach is mainly used in various pathologies, and we can discuss by sample of sphenoid ring meningiomas. There are a lot of classification of such tumors, but basically they are classified according to their origin in lateral, medial, or middle, and they have to be differentiated from anteroclinoid meningiomas. This is the kind of tumor you will face and easily access through a pterional approach. You see this big lateral sphenoid ring meningioma before and after the surgery. Another one, those can be easily accessed to a pterional approach. And I would like to discuss with you some more difficult lesions. This tumor looks very convenient, small tumor, but in fact was highly vascularized. You can see that on the vessels that are surrounding, venous vessels are very impressive. And I would say this was a nightmare, and just making the bone opening was resulting in very massive bleeding. And this is the first time it arrived in my career. I have to stop the surgery and send the patient for an angiogram. And then after embolization, the patients went back to the operating room and was operated on. The tumor vascularization was very impressive at that time. This is how it looks after the embolization, like an AVM. This tumor is also extremely vascularized, as was not able to vascularize to embolize the lesion because most of the feeding vessels were coming also from the internal carotid artery. This tumor was resected through a pterional approach with perfect result, but also a very highly vascularized tumors. The interest of the pterional approach is to get a control of all the feeding vessel at the cranial base, but also intradurally. What can happen when we are treating sphenoid meningiomas? It looks very easy, small tumor, but have a look with what can happen. And there is some combination, and when we are treating with skull-based tumor, we have to be able to manage also the vessel. This is the tumor. You will see the dissection. What is important is to dissect the vein. The vein have to be preserved. You see how it is adherent. The principle of skull-based surgery is to make an inner debulking of the tumor before dissecting the periphery of the tumor. And you will see this vessel very adherent to the tumor, very important vessel. You will see the diameter of the vessel is quite high at this level. The dissection is quite hard. You will see that the vessel comes very easily up to the point where a small pseudoaneurysm will happen. And you will see very small tumor, but at the end, not so easy to handle. You see here the development of a small pseudoaneurysm. So it's why I say when we are performing skull-based procedure, you have to be familiar also with the management of the vessels. This is the dissection of this important temporal branch. So what to do? It's why I show you this case. to leave in place in this situation, to make a trapping, to make reinforcement. The time I asked me what to do, and the vessel spontaneously ruptured. It was patent. So in order to have a perfect control of the situation, finally, we have no other choice to repair the vessel, placing a clip, you will see, on the vessel, and then suturing the vessel in order to let the vessel completely patent. I was surprised before operating this small tumor that it will finally end with a more complex surgery, but you have also to be prepared for that. The vein dissection, the arterial dissection can be difficult even in small lesions, very adherent lesions. This is the postoperative control, and you can see there is absolutely no flare lesions, illustrating the importance of being able to manipulate the vessels. Another very interesting case of sphenoid-ring meningioma to show you that those meningiomas can disturb the venous outflow. This meningioma was associated with the very severe edema, and after the surgery, this edema almost completely resolved. The pterional approach is also convenient to reach clinoidal meningiomas. Very interesting because you have the control of all the vessels. And I will discuss finally with you a very interesting case for me, a temporal cavernoma. You will not blame me, it's not a skull-based tumor, but you will see the principle applied for a skull-based pathology are applied during this surgery for this very impressive cavernoma, reaching the brainstem, reaching all the structure in the interpeduncular fossa in relation with all the vessel, the carotid, all the branches. You will see that during the surgery, during the video. You see the relation with the sylvian fissure, mainly below, but also above the sylvian fissure. So this is how it looks at surgery, the frontal lobe, the temporal lobe. This is the releasing of the CSF at the carotid-optic fissure. You see the opening of the sylvian fissure, the sparing, of course, of all the vein. Then I work in the cavernoma. You will see the cavernoma through an anterior transtemporal approach. This is how looks the cavernoma with a very adherent hemosiderin ring, very difficult to dissect. This is the usual aspect of a cavernoma. Then you will see the cavernoma in close relation with all the structure. So there is a need to completely open the sylvian fissure, and you will see the technique. I almost never use cottons. You will see all the procedure is performed without retractor. We've seen just before the M1 segment. This is the preservation of the vein. You will see just into view the third cranial nerve. The third cranial nerve is here. You see the dissection of the PCOM. This is the main principle used in skull-based surgery. You see all important vessels, the PCOM and branches, the anterior choroidal artery, and gently the temporal lobe is separated from the M1 perforators. A very careful dissection, of course, not to tear any vessel from the main one, otherwise you will be in trouble. Opening the good plane is very relevant. Then you see the dissection around the third cranial nerve, separation of the adherences. Unfortunately, the cavernoma was adherent to the structure, so careful dissection is needed. The cavernoma is below the third cranial nerve. Very adherent also, even if there is a pial layer, to all the vessels. The objective of the first resection to the transtemporal axis was to release the mass effect. Important to release the mass effect before performing the peripheral dissection. As in skull-based lesion, this is the cavernoma extension, again, against the third cranial nerve. Then the dissection of all the perforators is of crucial importance. And now you see how the cavernoma extends along all those vessels. Careful separation, no retraction, no blade. perfect vision. I almost don't use the bipolar, just the forceps to do it. You can open the cavernoma in order to release the mass effect. At some point, coagulate a little the cavernoma to retract the lesion. This is made right now. It's like a meningioma, a very massive cavernoma. Retraction of the lesion. You perfectly see now the P1 segment. Now I continue the dissection along the free border of the tentorium, following the PCOM. You will see the importance of protecting all microvessel coming from the PCOM. If the mass effect is too big, you have to release this mass effect, continuing to resect the cavernomas from inside the temporal lobe. What is relevant is you see small aneurysm in some part of the cavernomas, making me thinking that the risk of hemorrhage was quite high. This is the PCOM that is followed from outside the pia mater, but also from inside the pia mater. So you see the tentorium. When you see the tentorium, you know that you are safe to resect the lesion caudally. The most dangerous part is medial to the tentorium. The tumor is resected piecemeal, debulked, gently debulked, progressively aspirated with the CUSA, dissected in its surrounding. You see the typical aspect of the cavernoma, preservation of some arterial branches. You see how big was the mass of this lesion. And you will see in a few seconds how it is important to coagulate the feeding vessel. In this case, there was 2 feeding vessels. Then this is the dissection from the PCOM again and the posterior cerebral artery. Then you think that you are at the end of the surgery, but take care of against all the perforators. All those perforators, of course, have to be preserved. We are at the end of the surgery, but one small vessel is still visible and need a very careful dissection. Any injury to such a vessel can have a devastating consequence. So this is the end of the procedure after complete resection of this, I will say tumor, but it was a cavernoma with a tumor-like appearance. And this is the end of the procedure after complete resection through a transsylvian and transtemporal approach. This is the postoperative control after complete resection of the lesion. And then I enjoy to make a flare postoperatively in order to be sure that they have not induced any injury to very important structure. This is the patient 10 days after the surgery. You can see it's a mini-pterional approach. The patient has absolutely no deficit. So it was for me interesting to show you all the indications and possible access to this pterional approach to various lesions. And I will now give the opportunity to Jan Cornelius to maybe a little more focus on the mini-pterional approach.
Yes, thank you very much, Michael, for this very nice presentation. So I will just go on a little bit with what you and Stefan already presented. So the basic principles, of course, of the mini-pterional approach are the same. The anatomic basics are the same. So So my talk is compact. This is the plan, and
Jan, we cannot see your presentation.
You can see it?
We cannot.
Oh, sorry.
If you can try again to share.
Now it should be okay.
Still not. Okay, if you can try again now.
If it doesn't work yet, I can jump in and we can just flip the sequence.
Yes, that could be a good proposal.
Yes.
So Eckhard, do you want to go for?
Yeah, Jan, is that okay with you?
Yeah, go ahead.
Okay.
I will try to figure out what the problem is.
Okay, so Michael and the ENS team, thank you very much for having me. I'm joining in to share my screen. I hope this works. Can you guys see it?
Yes.
Yes.
All right, then we need to briefly go for slideshow.
Mm-hmm.
All right, so I'm going to contribute today a talk on the management of giant olfactory groove meningiomas. And you may ask, why this topic within a series of talks on the pterional approach? And the answer is rather simple. I started off with maximal approaches, bifrontal, and it took me a couple of years to actually distill out the information that was necessary to arrive at a much smaller approach. And I think the pterional or modification of pterional approach is excellent for this particular topic. Disclosures, I have none to make other than that I've given a previous version of this talk at a meeting of the PANS. To give you some background, meningiomas are the second most frequent primary brain neoplasms. They make about a third of tumor volume in a unselected brain tumor clinics with a ratio of 2:1 females to males. And most meningiomas show up in the second half of life around the 5th decade, more so later. Amongst these, the olfactory groove meningiomas make up about 10%. And as most of you know, they arise at the midline dura from the anterior cranial fossa, somewhere between the cribriform plate and the frontosphenoidal suture, or between the crista galli and the dorsum cellae, but they're really more anteriorly located. They are not planum sphenoidale meningiomas. Blood supply to these arises from the anterior and posterior ethmoidal arteries, and sometimes they can draw branches in from the ACA or ACOM. When you think about olfactory groove meningiomas, the definition of a giant olfactory groove meningioma is one that has a diameter of greater than 5 by 5 centimeters, but this was a paper by Gazzeri that I think defined this well as so-called the equivalent diameter. And when you look at these very large tumors, they still follow the normal distribution of meningiomas, with 2/3 of female patients afflicted, a mean age in the mid-50s, and it takes about 2.5 to 3 years to actually present with symptoms and make it to a specialist before most of these patients underwent imaging. And I tell you the reason why. So one of the problems with these large, slow-growing lesions is the insidious onset, which leads to a delay in diagnosis, although the diagnosis can come from a number of different symptoms. Many patients show up with anosmia, some form of frontal lobe syndrome, and often classified rather unspecifically as dementia. These can just be changes in mentation, frontal lobe syndromes, executive dysfunctions, but they can be negative symptoms such as depression or lethargy, or positive symptoms where patients present with hallucinations, even psychosis or mania, and a few patients have been described with schizophrenia. Sometimes patients present with headaches, failing vision, seizures, or frontal release, such as urinary incontinence. When you look at a larger series that reported on this, what's the frequency of these symptoms? Well, about 50% of patients actually do have some form of a headache, often misdiagnosed as a migraine. 2/3 of patients have mental status changes when formally tested. Almost half of the patients have some form of visual loss, and about 2/3 of patients present with inability to smell. Now, one of the problems with this slow onset of diagnoses and slow presentation is that many patients are treated for years for a presumed diagnosis of something else. Psychosis is quite frequent. Glaucoma, a lot of these patients end up going to an optometrist on a regular basis because they never get imaging of the background of the eye or behind. Sinusitis, stroke, stress incontinence, all these have been described really well. And noteworthy was an observation made by Zilch that frontal meningiomas are more frequently found in mental hospitals than at autopsy. And if you think about that statement, it should really remind you that no patient should go to a mental institution for long term without any intracranial imaging, because you will be surprised how many things you will discover. With respect to visual symptoms, it could be a reduced vision, papillary edema, optic atrophy. Visual acuity is affected in almost half of the patients, but 20% of them show up with visual field defects, and about 1/4 has some form of optic disc power. Now, with respect to eye symptoms, two things are noteworthy. The optic nerve in these tumors is compressed from superiorly, so if you find a visual field defect, it's usually inferior. And the famous Foster-Kennedy syndrome was actually described in olfactory groove meningiomas with this compression of unilateral optic nerve and condylar papillary edema. Now, historic aspect, I think it was really stunning for me to learn that the first successful removal of a large olfactory groove meningioma happened more than 100 years ago, and that patient survived without antibiotics, without a microscope, without image guidance, without any significant perioperative complications for 12 years, and was described in 1885 in Italy. Pre-surgery, pre-CAT scan, the surgical mortality for this lesion was actually stunningly high, and only in the last 20 years we have significantly improved to a mortality of 1 to 10%, which is still a high number. But considering the size and impact of the lesions, I want to show you why. The question remains, what's the best approach here? So this is an algorithm I use on a regular basis where I say, if the patient is non-incidental, so presents as a symptomatic patient, these are surgical lesions. One should really take the patient to surgery unless there's a contraindication to surgery. But if the patient is non-surgical for cardiac reasons, needs to stay on a blood thinner, or simply cannot be operated on, one needs to think about symptomatic treatment, which can be a number of options that goes beyond the scope of this talk. For incidental lesions smaller than 3 centimeter, wait and watch and see what happens, I think is an important concept. You cannot make a patient better who has no symptoms. So if you really test the patient and the patient was scanned because they fell down a set of stairs and they have a 2 centimeter olfactory groove meningioma, the patient has no symptoms, wait and watch, don't take it out just because it's an appealing lesion. Now, what's the best surgical approach to these? If you want to read one single paper on the topic, this one by Spector in Operative Neurosurgery from 2005 is the paper to read. Outstanding paper that compares all surgical approaches with pros and cons out of one single center, exceptionally well done. So I want to take you through this. What's the debate here? Well, what are the goals of olfactory groove surgery? First of all, do we want to achieve a complete resection, gross total resection, or maybe a subtotal resection is good enough, versus a few cases where debulking may be the goal, because if the patient is late 80s and you think you do not have to accomplish a complete resection because the patient will never live long enough to require complete decompression, that is a fair discussion to have. Don't be overly aggressive. How do we achieve early interruption of the blood supply? So you need to study this and think about this well. How do you separate this tumor from the frontal lobes? How do you dissect off involved vessels, if there are any, or vascular structure or neural structures? And how do you get best access and see the flow of the anterior cranial fossa, because that's where the critical structures are. So early debates in the United States really hinged around, should one try a unilateral approach and do a cortical wedge resection, take out the compressed brain that overlies this lesion? This was largely championed by Cushing. And since lots of people emulated what Cushing said, it was a predominant way of taking care of this for a long time. whereas his big counterpart, Dandy, always advocated for a bilateral frontal traphination. And there were lots of cases described in the early literature with these big approaches. In Europe, a remarkable series were published by Oliver Kroner. And here the interesting statement really is a different one. He early on noticed, as neurosurgery was developing across various centers in Europe, that with brain tumors distributed across various neurosurgical clinics, it may be hard for the future generation of neurosurgeons to acquire enough experience with these to really make a good informed decision. And then it very much depends on where you trained and what you learned and your choice of how to get there best. So initially, they discussed more of these options. Should we go midline, fronto-basal, and take out just the easiest access route in the front? And that was championed in Germany by Tönnes, and then picked up by Ogeman in the United States, and transported into this century. And there's even a subcranial transbasal approach described in France that is very popular because it avoids a lot of the structures, but it takes out the frontal sinus, which has its own complications. So when I started doing this, I trained at Mass General in Boston under Ogeman, and everybody took these out with a bifrontal approach, which you see here from the burr hole distribution. It's a huge surgical access. You basically take out the entire forefront and you resect the anterior forks and you tie off the superior sagittal sinus to get to the lesion. And that may be the right thing for some complicated region that reaches high up and involves a lot of dura, but maybe it's not. The pre-surgical workup for these large access surgeries should include a CTA and CTV. I think you need to know where your vessels are coming from and what is the drainage pattern of the tumor and the surface of the brain. And I occasionally even obtained an angiogram early on. These days, I think CTAs are good enough and should work well. And I always get a formal ophthalmology and psychology examination prior to surgery. When you do big surgery, you should use a protocolized approach. I use a cocktail of intraoperative mannitol, Lasix, and Decadron to achieve proper brain relaxation, especially if you don't want to use stationary retractors. I have a rule of 30s that the higher bed should be elevated to 30 degrees. You should hyperventilate the patient to an end-tidal CO2 of 30, and your crit should never drop down to less than 30. That will help the patient to have adequate perfusion. I plan for a bilateral pericranial flap as described in the literature. I always exenterate the frontal sinus. I use an abdominal fat graft to pack the sinus, and I may possibly use a lumbar drain if there's a concern for difficult closure. So these are very important steps in your pre-surgical planning and positioning of the patient to get it right. But this is how it looks. It's big surgery. You take out the entire forefront. You basically try to take out not just the access point, you try to go as low as possible at the level of the sinus to look straight into the anterior cranial fossa. And you can achieve good outcome. This was the immediate post-op resection, persistent edema on the frontal lobe. 3 months later, the frontal lobe has nicely recovered and filled the gap, but the edema actually remained because it wasn't just edema, it was loss of some of the cortical surface vessels, and thereby the patients often continue to have significant executive dysfunction in these cases. Now, my evolving thoughts on this topic was, is this really the right approach? Because I had one patient, for whatever reason, where the bone flap was reabsorbed because of some immunology reaction, and she lost the entire forefront. And I really thought, this is a terribly debilitating operation. It's very difficult to reconstruct this because it has a big impact should you ever get an infection in this area or lose the bone flap. So can we do any better? Well, I went back to the literature and looked at what other people had tried. And there's this interesting school of thought that came out of Freiburg and Seger's school, which was maybe we could do a bifrontal operation, but only choose access from left and right and leave the midline structures where they are. He tried this in 35 cases, but still had a CSF leak in 6 out of 35 and a significant infection rate. But it was a smart idea to not take down the frontal sinus and the veins on the surface and not even dissect out the frontal forks. This was then later developed by Hassler and Sentner, who said, maybe we can try this from one side only. They are really the first ones championing the pterional approach for this particular problem, with the idea that you come in from the right side, you work across the midline from the larger side of the lesion, You take out the forks in the middle and you reach across the midline to decompress the opposite side last. And that actually allows you to preserve olfaction on the contralateral side, which works really well. So I thought it was an interesting approach and tried this. And then I did some more reading and I thought maybe I should combine a pterional approach with a subfrontal approach, because that would allow us to get better access and viewing from the front. And it also gives you better access to the skull base in case you want to drill out the hyperostotic lesion at the skull base. So this is what I currently do, even for large tumors. I combine a pterional approach and extend it with a frontolateral subfrontal approach on one side, and it works for really large lesions as well as for small lesions. I always get my pre-surgical DSA or CTA. In this case, you saw calcifications as well as blood supply from the anterior ethmoidals feeding this tumor just from the middle up. There was a large displaced ACA draped over the tumor that I didn't want to lose. So I wanted to be careful about this. There was calcification at the skull base. So I had 3 challenges in this case. I use pre-surgical scout images and image guidance to map my approach because I want to come as low as possible, but not violate the sinus. So the pearl taking away from this case is use intraoperative image guidance not to find this tumor. The tumor is 5 by 5 centimeters. You can't miss it, but you want to bring down your osteotomy right in the midline and you want to stop right above the frontal sinus on the side where the sinus is lower. And you can avoid falling into the sinus. You can leave a 3 millimeter bone bridge and you will be able to preserve your frontal sinus, never run into a CSF leak. The second thing is laterally drill away the side of the orbital roof and this corner point, and you can drill down a portion of the orbital roof to get better viewing angle into the middle of the anterior cranial fossa where your blood supply comes from. So you get a low anterior approach and you are able to take this tumor out from a unilateral viewing angle with essentially no problems. I always get DWIs post-op just to check what my perioperative stroke rate would be, and I can assure you it's minuscule. I have not lost any major vessels using this particular combination. Now, what have other people done lately? And you will see a paper hopefully coming out of this ENS skull base group in the future. The problem is that most recent literature does not differentiate specifically what each of these approaches has to offer and what risk would you pay for it. So in general, gross total resection rate is reported between 60 and 100%. And that may just be the difference of 60% if you leave the hyperostotic bone in, 100% if you remove all soft tissue. And we need to come up with a proper definition how we compare serious one versus the other. Clinical improvement is reported in 60 to 100% of patients. And that may differ a little bit depending on what approach you use. So I want to show you all series that have looked at this carefully and did some form of mini-mental status exam show that if you do an adequate decompression within 1 month, the patient with the olfactory groove meningioma resected reaches a score that is within the range of normal on the mini-mental status exam, which is pretty remarkable. They were often running around for years with so-called dementia and executive dysfunction, but most of these patients can recover nicely. 25% show an improvement in vision, 28% show an improvement in visual field defects. Then we look at how is, with unilateral approaches, the completeness of resection, 90 to 98%, it depends a little bit on how you define this, show an improvement. Mini-mental status, as I said, improved in this series in all patients, vision improved in 93% of patients, so very good numbers. The patient wants to know not necessarily how beautiful does your picture look, but what's my risk for this type of big surgery? So I try to take my patients through this and say, well, risks come in 2 flavors. There are major complications, which I really classified according to Grondin's paper, written for a different purpose, but it's very nicely done, into permanent neurological deficit. And you should really have none with olfactory groove meningiomas if you have done it well, except the pre-existing neurological deficit of visual field parlor from optic atrophy, which you can't reverse. Minor complications, transient, seizure, CSF leak, wound infection, so on, ranges about 5 to 8%. So when I looked at the series across the literature again, currently the reported CSF leak rate is about 5% for these patients. The reported cumulative risk across visual loss, CSF leak, infection, seizures, and infarct is about 8%. So it's not a benign procedure. You need to realize this is still maximum surgery for a big problem. But compared to previous reports of 30% mortality about 30 years ago, 10% mortality 20 years ago, we currently work on these patients with a mortality of about 1%, which is usually perioperative thromboembolism, DVTs, and PEs, and not related directly to the surgery. So what is happening recently in the field? There are more and more debates going on. Can we make this even smaller? Sami's group has always advocated a very small frontolateral approach, which I think is nice. That's why I extended my pterional approach to coming in from more frontally, because the subfrontal approach gives you more direct access to the cranial base and allows you earlier devascularization of the tumor, which may be a bit harder if you come in from the side. And the pterional approach helps you to really see the optic apparatus in a better way in the ACAs. So I think by combining the two, as I've shown you, you have both advantages and you stay on one side. Then more recently, there's a push towards doing everything minimal invasive and more minimal invasive. And here I want to caution you a little bit, because I think the concept of minimal invasive is often not well described. It's really minimal invasive with respect to the patient and their side effects. So even if you have a rather big access corridor, but the patient has minimal morbidity, I think you may be better off than having a small keel approach with more side effects. And here the problem is that the series, again, are not equivalent in what they report on. So Charlie Theo, who's a fantastic surgeon, don't get me wrong, reports on he can take anything out through the nose, but the tumors are not exactly the same that we were talking about. Some of them are more posteriorly located in the frontal cranial fossa, and the reason is there would be more a planum sphenoidale meningioma. And the reason is that you can see on this picture, coming in from the nose is a lot easier if the lesion is located closer to the sella. The more you are anteriorly, the steeper is your viewing angle, and it's really hard to get up there and not take out both olfactory bulbs when you remove this lesion. And the loss of the sense of smell, I consider a significant compromise in quality of life. And I want to caution you against that, because I think patients haven't realized that if they can't smell, they usually can't taste, they don't enjoy life as much. They have a difficult time in public if they get older and they run into incontinence problem. They don't smell what the neighbor smells, and they want to understand, why are people looking at them funny? And it's really a quality of life issue where you can help out and say, if I can preserve olfaction, then I should maybe consider a unilateral approach that is open frontal with less CSF leaks, and I have good quality of life preserved for this patient, rather than coming in through the nose and trying a 6 or 8 hour operation to chisel a 5 centimeter tumor out through a 3 centimeter hole, which I think may be hard. But that's an open debate, and I want to invite you to participate this in the future. Thank you very much for listening.
Thank you so much, Ek. Will you stay with us for a few minutes after the talk of Jan Cornelius, if we have some questions for you, or you prefer now?
No, I'm sure. If anybody would like to chime in, or if you, as the panel, would like to ask, please go ahead.
But you will stay with us still 30 minutes, so I will.
I can hang out.
Okay, so once again,
it's incredible, Jan. We tested before starting the webinar. It works.
Does it work for you now?
No.
Not yet.
We see the black screen, so we see something. So if you can unshare and share again.
Or maybe disconnect from the Zoom and reconnect to the Zoom as well.
Yeah, that is a good idea, Jan.
All right. See you.
See you.
See you in a few seconds. Ek, are you with us?
I'm still here.
Few people are speaking about the anterior interhemispheric approach I used. I have to publish my own result about this this approach. I will say that I appreciate a lot the anterior interhemispheric approach because it's just a craniotomy that is made above the frontal sinus, as you have explained it, also in order to respect the sinus and finally to decrease the morbidity. And through this approach, working on the midline, you are able to always attract the tumor remnant inside the hole that you have created. And I found that the brain retraction at the end was very, very limited. And because you are making the bone opening very anteriorly, the risk for the bridging vein are quite limited. And I found this approach very interesting, especially for those olfactory growth meningiomas having a cranial extension, because I expect that through approaching through the cranial base, the superior extension of the olfactory growth meningioma could be more difficult to reach. Any comment about that?
No, I like that approach as well for the very reasons that you mentioned. You come in above the sinus, the frontal sinus, which takes the CSF leak out of the picture largely, and you have a good chance to preserve the frontal wings. The one reason why I dislike the approach is you operate a chimney down, and the last thing you see is the blood supply. So you basically run into the problem that you decore the tumor. Meanwhile, the tumor still has its full blood supply from underneath. So my frontal approach concept was, if I devascularize the tumor first through the frontal portion of my axis, I have a completely dry field. And I can then piecemeal a dead tumor out that has no perfusion. So I have not needed any transfusions. I'm not leaving anything behind. And I felt that was, in my hands, a successful strategy. But from reading your papers, I have to admit, I'm interested in maybe trying this if the anatomy is favorable. Coming in anterior interhemispheric and also going low maybe first, and separate half of the tumor from the upper portion will give you the same result. I agree. I have just left that out of my presentation.
But tips and tricks, maybe also using this approach, I go quite straightforwardly to the base. And so I'm quite also able to devascularize quite early in the procedure the tumor, especially since the origin of the tumor is on the midline. If you create a hole directly on the midline to the basis, you have devascularized the lesion, and then the lateral part of the lesions that are remaining are completely devascularized before attracted in the hole that you have created. But it's just a tips and tricks that I find over the years.
No, good points. Definitely worthwhile. But I see that Jan Cornelia is up for presentation at this point. We can see his screen. Should we?
Yes, good, Jan.
Let him go ahead.
Oh. So I had a bug. Sorry for the inconvenience. Well, I'm going to talk about the Mini-pterional approach and what about the miniaturization of our approaches. Nowadays, we have to face as surgeons the fact that many skull-based pathologies or also vascular pathologies may be treated by radiosurgery or endovascular treatments. So we have to miniaturize our approaches in order to reduce the surgical trauma, to reduce pain, to shortening the hospitalization times, and for better cosmetic results. So this is the rationale for miniaturization, but it should not come with a compromise of safety or efficacy. So this is an overview of the history. So it started with Dendy in 1938 with a frontolateral approach, and then in 1975, Professor Yajagil, the pterional approach, and then around 2000, the mini approaches or the QL approaches that we have today. So basically, we can subdivide the evolution in the pre-microsurgical area, and then with the advent of the operating microscope, we had an early and a later microsurgical area, and now the present time. So this is an illustration of the frontotemporal approach as described by Dandy. And this is so our pterional approach. And then we have more to the midline, the supraorbital approach, and more laterally, the mini-pterional approach. And somewhat in between the both, we have the lateral supraorbital approach. So when considering the mini-pterional versus the supraorbital, so there is a landmark, which is the superior temporal line. So the supraorbital craniotomy is medially, and the mini-pterional approach is laterally off that line. So if we compare the pterional to the mini-pterional, so on the upper, you have the classic pterional, as nicely described by Michael. So on the lower, you have the mini-pterional, so which is more centered on the pterion, which is encircled by the green circle, and the dotted lines outline the skin incision. So basically, you have everything which is centered on the pterion. So at the beginning, there were a lot of concerns and critical questions like, are these keyhole approaches, is the exposure too limited, or is the freedom of the instrument too restricted? Are aneurysms or ruptured aneurysms, are they operable? Are more complex situations, bigger aneurysms or bigger tumors, are they operable via these small keyholes? So there are, if we group the problems or the concerns, there are approach-related factors like the opening of the skull, the craniotomy, the trajectory, and the exposure of the surgical field, and the view of the surgeon and the surgical freedom of the instruments, so which may be enhanced by endoscopic or angled instruments. And then on the other side, we have pathology-related factors like the rupture status of an aneurysm, the tumor size, the overall view, which may be hampered by edema or hematoma, and then morphological factors of the aneurysm or the tumor, and other anatomical factors like the vessel anatomy. So there have been a lot of anatomical studies, and this is the original paper which was published in 2007 by the Spetzler group, which first described or coined the term mini-pterional craniotomy. And then over the time, there were a lot of other papers which were done in anatomic labs. So they were comparing, for example, the microscopic versus the endoscopic view, or they were comparing different type of mini approaches, like for example, the mini-pterional versus a supraorbital keyhole approach. And there were also quantitative analysis of all these approaches. And what's the bottom line? The bottom line is that there is, for the mini-pterional approach, there's no real difference for the area that can be reached or the different angle of exposures if one considers the MCA, the ICA, and the ACOM area as a surgical target. And there's a slight preference to treat ACOM lesions, aneurysms, by a more medial supraorbital approach, and the MCA and ICA lesions by more lateral, so the mini-pterional approach. So what about clinical applications? So there is a lot of literature of vascular pathologies actually, and what came out is that these approaches are feasible, they are safe, so especially for aneurysms, they were not correlated with higher intraoperative rupture rate of the aneurysms, and the patient had good outcomes. Operating time was shortened as expected, and the hospital stay also, which comes with secondary advantages. So this is an overview of the vascular pathologies that may be reached by the corridor. So it's along the axis of the middle cerebral artery and then going to the carotid artery here and then to the very central part, for example, for ophthalmic artery aneurysms. But in analogy, you can also treat this kind of tumors. So they are in the axis of the sphenoid ridge, basically, which usually also need a Sylvian dissection. So tumors located here at the central skull base. So the patient positioning is more or less the same than for a classic pterional approach. You apply a Mayfield head holder, slight extension of the head, and then you have to look for the head rotation. So this is a bit more, you have to think really about the opening, the trajectory, and the target that you want to reach. So for a MCA aneurysm, the head will be slightly rotated more than, for example, for an ICA aneurysm. So for the skin incision, so it's like the pterional approach, 1 centimeter behind the hairline, but then the extension of the incision is from the lateral canthus to the mid-pupillary line. So this is about distance of about 4.5 centimeters. And then you want to dissect the interfacial pad, as was nicely shown by Stefan in his anatomical presentation earlier. And then you actually you cut both leaflets of the temporal fascia and actually do subfacial dissection. And when splitting the muscles, we usually do that bluntly, just with a spatula, and do it parallel to the course of the muscle fibers, not to cause any atrophy. And then the placement of the burr hole, it's slightly anterior to the pterion, and it was nicely explained by Michael, so that this burr hole should expose a bit of the frontal dura and a bit of the temporal dura, and then you perform a craniotomy, which is about a circle 3 by 3, or an ellipsoid with a diameter of 3 by 4, something like that. And if you have the dura open, did the dissection, this is the view that you get in the depth. So with the optic nerve, the internal carotid artery, A1 segment, M1 segment, and the MCA bifurcation. So basically here is a summary. When you put the pterional and the mini-pterional approach side by side, so the main difference is the size of the craniotomy, the bone opening, and of course the areas that you may reach intradurally. Nowadays you have some advantages, some help. So one important thing is the preoperative planning, 3D planning with the mirror navigation, or even coming up technologies like the virtual reality. So before surgery, you can actually plan the best entry, the trajectory, and your target area. We also have intraoperative aids like the mirror navigation and endoscope, angled instruments, and also coming up augmented reality, which can be shown in the microscopes. So just to illustrate it clinically, here is a case of a 69-year-old man which had has headaches and did a routine CT scan. He is a heavy smoker and had an arterial hypertension, so there was a suspicion here of a MCA aneurysm, which was confirmed in the CTA, and then the patient got angiography, and this is short operating video which actually illustrates the sorry. So this is the dural opening, and then you do the dissection of the arachnoidea, sharp dissection. So it doesn't need to be a very long opening of the arachnoid, and then preparation here of the aneurysm. And then the clip application. With the Doppler checking the vessels and doing ICG. And then at the end, puncture the aneurysm and coagulate. So this is the postoperative result, and this is the size of the craniotomy. So it's an opening of about 3 to 4 centimeters. And well, I'd like to finish the presentation with a critical voice and a voice of reason, quoting Bernard Georges, who said that speaking of the Mini-pterional approach in response to the article which was published in 2007, that enlarging or minimizing the bone opening is just a question of experience. And then he says that the extension towards the subfrontal region needs a frontal-pterional approach, and toward the temporal fossa, temporo-pterional approach. And I think this is a process. So if you are doing as a trainee or a surgeon, the transition from classic to keyhole, you have to go step by step. So before going on the right, you have to start and go slowly. And it's an analogy, for example, to spine surgery. So if you have done your experience in open cases, you can progress and go by tube systems or even by endoscopes. And I think the main conclusion of the talk is that you as a surgeon have to feel comfortable with the approach and the pathology in a given patient. So you have to do a careful analysis of your preoperative images and do a careful surgical planning. So work with a dynamic retraction, and especially in aneurysm surgery, you have to be mentally prepared for a complication, a rupture, and then in your surgical experience that you show that you should progress gradually, because I think safety is the most important thing. So thank you very much for your attention, and I'd like to attract your attention to a hands-on course that is going to take place in May here in Düsseldorf in Germany. And so this is a save the date, and the exact details will follow shortly on the ANS website homepage. Thank you very much.
Hello, voilà, Yann. Very nice presentation. Thank you so much. Very interesting your talk about mini craniotomy, and I agree with you and Bernard Georges that the main point for performing a mini craniotomy is the experience, and the size of the craniotomy is one point, but the other one, the craniotomy should be perfectly located. So the error is very limited, and the access will be good or not with a few millimeters of difference. And most of the time when I use most commonly mini craniotomies, but when the resident make the approach, most of the time you have just to adjust a little, maybe drill 5 millimeters away, and it is those 5 millimeters that the experienced surgeons know that he has to use in order to have a perfect exposure of the pathology. That is why mini craniotomies are more dedicated for more experienced people.
Yes, it's exactly right what you said, and it's I remember a talk of Nikolai Hopf from Germany. He said that actually keyhole surgeons or experienced surgeons, they have to perform the keyhole by themselves. So it's always difficult to want to perform a keyhole procedure where you did not perform the craniotomy, because as you said, it's a matter of experience, and it for a very small craniotomy, if it's off only by 1 centimeter or something, it becomes very difficult.
Ekar is no more with us, but it's a little provocative for the ones who are doing also endoscopic surgery. But I remove olfactory growth meningioma with the dural incision, which is a nostril approach. I measure the length of the dural incision, and it is 15 millimeters. So it's the same than a nostril. So to a very small approach, you can remove big lesions, and as much the lesion is dislocated, as much the craniotomy can be smaller. It's only for more superficial lesions that the craniotomy must be a little more large.
Maybe one thing for olfactory meningioma, I think the transbasal approach is missing, because this is a bit of combination. It's early vascular control, less retraction, no problems or much fewer problems with dural closure and CSF leak when compared to endonasal. Of course, it's a more complex skull-based approach, but I think this is a feasible option also.
Mika, I just wanted you to comment on the dissection of the temporalis muscle. You always do it with a Bowie counter, or sometimes
the dissection of the inner part, never with coagulation, never.
Yes.
Just to cut the muscle 5 millimeters away from the temporal superior line, just at this level with the cutting. But
yes.
Otherwise, it's always, you cannot use any burning system on the inner aspect of the muscle. You should perform a retrograde dissection, as this was discussed in the chat, in order to maintain this protective layer of periosteal layer, in order to protect the vascularization and the innervation, especially the innervation of the temporalis muscle.
Yes, I think that is important to point out that the dissection has to be not with a Bowie, not with a high temperature, but
yes, never,
and retrogradally from posterior to anterior to spare the yes.
If you use the monopolar cautery on the inner aspect of the temporalis muscle, the muscle is gone.
Yes,
definitely, it's forbidden. Any other comments of one of you? I think we have a very nice webinar this evening, I will say now, and a webinar of 2 hours. So it will be my pleasure to be with you. I think we will end up now, and I give you the opportunity to join us again for the next skill-based webinar in 1 month. Usually it is the 3rd week of the month. So thank you to all of you who attend the webinar. I see that you are coming from all across the world. It's impressive. We are proud to give you those lectures, and it will be my pleasure. I will be pleased to meet you again within 1 month. So Jan, thank you. Stefan, thank you. I appreciate also the talk of Eckhard Kasper, but he's no more with us now. So see you soon, guys, and take care in the meantime.
Thank you, Michael, for organizing and nicely moderating all those sessions. Excellent. Bye-bye.
Thank you very much, Jan. Bye-bye.